Thank you very much. Good afternoon, everybody, and warm welcome to EASL Studio. EASL Studio is a weekly hepatology broadcast news where EASL do a live studio every Wednesday at 6 o'clock Central European time. So if you've not listened in it, try to listen in. It's free for everybody. It's available on Google, Apple, Spotify, and YouTube. And we discuss hot topics in hepatology. So for those of you who don't know it, so the format here, we don't show any slides, we don't show any data, and there's no long talk. So my task is basically a moderator to have these. These are some of the brightest minds in this field in the world. So it's really privileged to have these people. So we want to challenge them. We don't want to have necessary consensus, because rarely we have consensus. And we have US represented by 2 Indians, but that's lovely. But today you represent United States, and then we have Europe, and then of course we have India. And again, we're here to inspire and learn from each other.
So hopefully we will have an Indian president of the US very soon as well.
That would be wonderful. That would be wonderful. So we chose the topic of steatotic liver disease. That is indeed a hot topic. 1 year ago, we got a new nomenclature. How is it going with that one? US got the first drug approved. Soon it will be around our regions too, and many more drugs coming. Yet there are several unanswered questions. How do we manage or build a healthcare system that can do that? All this and much more we will discuss. But also how we now integrate alcohol in steatotic liver disease. What challenges and opportunities does that give us? So we already had introduced this wonderful panel here, but I'd like to start maybe with you, Rohit. So if you were then the next Indian president of United States, and that meant that you had all the power, but you only have one assignment. That was in 5 years to be successful in this field. But choose one priority. So what would be really an important win in 5 years? Or where would you love to be in 5 years to reduce the burden of steatotic liver disease?
Thank you, Alec. I think the greatest unmet need is reversal of cirrhosis. And so if we could achieve that collectively, I think that would be the greatest disruption in terms of cycle for where our patients are and improving their lives.
Wonderful. So we will get back to that. So the point here is basically not F2 or 3, it's actually reversal of those. That is the next barrier to break. So Sven, from a perspective of Europe, what would be your key win in a 5 years period with the biggest potential impact for patients?
Yeah, I think there are 2 things, if I may. The first one is I think there is a lot that can be done just to prevent the consequences. We're focusing a lot on curation, but there is much more to win, I think, in terms of prevention. And the second one is, I think, the advanced stage and cirrhosis, better understanding it and finding a treatment for specifically that category of patients would be a big step forward.
So that's again, we'll get back to prevention and policy, because there are many, many different buttons we can press, and we probably need to press them all for that prevention. So AJ, from an Indian perspective, what would be a success criterion in a 5 years span for India?
I think we will understand that most of the liver diseases are preventable. So I think I will also like to focus mainly on next 5 years will be nothing, it's preventive hepatology. So it has preventive hepatology means we are talking today on steatotic liver disease, and the 2 major reasons for that being alcohol and the MASL D. I think we need to focus on that. But in that, I may also bring in maybe the virus-associated liver diseases also. So our focus would be on preventive hepatology, I would say.
Preventive hepatology. Again, important that comes back to changing, I think, our whole healthcare systems, because we are nowhere near that yet. So back to US, Arun. Now we looked at the 5 years perspective, but if you were now the next Indian president of the United States, I think that would be pretty good. Then what would be your executive decision? I understand that the American president have executive decisions. They can sign something and then it happens immediately. So what would you do signing now that would have immediately the biggest impact of patients in the United States?
So if I can share our experience with what we did with hepatitis C and see if we can replicate that for steatotic liver disease. So, you know, when hepatitis C drugs were coming through, they were considered extremely expensive. There was a lot of concern that only a small minority of people would have access to treatment. This would make no impact on the burden of disease. So in the US, and this is very US-centric, okay? So it may not apply everywhere else. The health policy is often influenced by the National Academy of Medicine. So we actually commissioned from EASL, I was on the governing board and I was sort of at that time. And it came to fruition during my presidency, where we got a report from it used to be called the Institute of Medicine, or the IOM, on viral hepatitis. And they laid out step by step, you know, the need for a surveillance system, access to therapy, and all of those kind of important things. And we translated that into language that was incorporated into congressional language and made part of health policy.
So that's basically a policy thing you would do. You
Absolutely.
would issue now.
Without health policy change, it is difficult to implement change at a macro level that has national impact. So if I had one decision to make, I would make assessment of metabolic health as an integrated concept, a primary healthcare, like a US Preventive Health Task Force, a quality metric and how individual physicians' performance is evaluated, and link it to access to care.
That sounds super ambitious and lovely. So, Sven, if now we got a female president for the European Union, but if you were to take over, we just shifted here a few months back, and then you can govern the European Union, what would be your decision for today that would impact tomorrow in a European context?
The European context is not that easy, but we are lucky that she's a physician, so she can think as we think. Again, I think prevention is key, so policy measures that improve health in general, both in terms of nutrition, physical activity, I think that would be the key way to go, but therefore we need real policy decisions that also shape how the industry works, because there is a lot coming from the industry, so we need to find a way.
Industry, is that the drug industry or the alcohol industry or the food
broad.
industry?
It's the whole nutrition industry, it's everything that has to do with lifestyle in a broad sense, so it's not just medical related to what medical science is, it's more society, nutrition.
So again, back to the more preventive approaches in terms of
I think
controlling.
in the long run, the big gain is there.
Yeah. SP now maybe also you, Francesco, from a European perspective, how would you see it?
So I totally agree with what Sven said. I would add the word awareness, because this is something that we pushed in our nomenclature. I mean, we didn't want stigma anymore in the metabolic disease, and I think awareness is very important, because the people, they don't even know that exists the metabolic liver disease.
So awareness among who or to among patients, physicians, politicians?
All of them, all of them. We want awareness 100% in the all direction.
Okay, SB, last of the line with ultimate powers for immediate impact. No, if India should choose to do something today, it would impact, huge impact tomorrow. What should they do?
I think you can't have anything which will have immediate impact tomorrow. You have to think in long terms. And I think prevention is the key, and for prevention, awareness is number one, and then other, execute decisions you can take. And for this, for me, catching them young is the key. So you have to inculcate this in the school education. Health education is a must in schools. And when we did a survey, most overweight people do not know that they are overweight. The concept of what is the right weight, what is obesity is not there in a population. So people need to be educated about that, because there is the key for, whether it is steatotic liver disease, whether it is other coronary artery disease and so on. So the key is educating school children and having health education, giving more priority to health education, which is not there currently.
So all the way down to the school, again, a very political, holistic approach to it. I think we could change a lot if we got the powers. But I still think that we are the ones actually to provide the knowledge so these people can take the right decisions. So now going on, we sort of opened up a little bit, but I have 3 things what I think we should prioritize to discuss. The first is focusing, even though we're moving away from silo thinking, I think that's the brilliance of the new nomenclature. You actually see it as a spectrum. But again, given the way we actually work on drug development is we discuss a little bit around MASLD MASH, and then the nomenclature. This is a 1-year-old child, how is it doing? And then about alcohol and mid-ALD. So for the MASLD MASH, I think I heard a little bit from you, but I think it's the same different priorities we have. So I have 6 different things here, and you're 6 people, so I want you to pick one each of you, and then explain why it's important or not, and the potential of overcoming these barriers. And again, I think it's very much linked to what you already said. So I think there are, if we just put them first, accelerated drug approval. So now we got the first drug. It's taken, I don't know, around 20 years to get here. We cannot wait so much. So how do we actually accelerate drug approval? Maybe along to what Rohit already said. Biomarker identification, biomarker that actually can qualify what we do. How do we know the drug are working? How do we find the patients? And then the public health initiative all the way up to WHO level. And then I think healthcare system integration. So we got all these dreams, but are our healthcare system ready? Mine are not. And I'll be surprised if yours are, given that the magnitude of patients. And then I think screening. Should we screen? Who, why, and how? And then a little bit of what I've heard you say, Arun, around multidisciplinary care. Is it really a liver disease, or is this metabolic health? Where are we moving? So I don't know, Francesco, you want to take a pick of one of these 3 topics here? Again, drugs, biomarkers, public health initiative, healthcare system, screening, multidisciplinary care.
So I would like to push something which was said before by Arun, because primary care is something that we can't miss. Like, we need to go in the primary care and push in that direction. So as we say, awareness is important, but we need to understand which patient and which person has to be screened. So starting from that point, we can get a huge help from primary care, and it's something that we can't miss. I mean, I'm talking about Italy. We're having lots of difficulties with GPs in Italy, but we need to go in that direction. Otherwise, we will keep having patients that get to our outpatient clinic with cirrhosis in 2024. This is not possible anymore. We can't get patients to go to the AI room because they have ascites, they didn't know about having liver disease. So I would push a lot in the primary care physicians to work together. Maybe at some point we might have some help from AI as well.
So that's basically the healthcare pathways.
Exactly.
What I call healthcare system integration, preparedness in the healthcare system. So no, I now want to pick a little bit on you. So that's easy to say, but how are we going to do it? Because there's shortage of healthcare workers. They all think they're overburdened, burned out, whatever, and there's a massive burden of patients. How do we get to prioritize? If we say that whatever, 1/3 of the population have steatotic liver disease, how do we do that?
So we do some like this, some kind of studio with the GP every Monday evening from 8:30 till 10:30, and we talk about every possible topics in GI and liver disease.
So you do that in Padua. You're a privileged guy there in a lovely university. How do you make that happen all the way down to the very southern part of Italy?
I'm just saying that. I think we can have some help about from politicians that push in that direction, but also from, for example, they ask me, why don't we use artificial intelligence in our rooms? Like the GP would like to have some software or artificial intelligence that do screen patients for metabolic liver disease.
That's a different question. So you got the healthcare pathway. So you didn't answer it. You didn't get an A, straight A, Francesco, but but that's just fine. Let's move on, AJ. Now, which one of these is again about the drugs, the biomarkers, let's say policy, WHO, and screening or multidisciplinary care? What do you think is a real
So I
approach?
think for me, I personally feel India, has a huge population. So and in the healthcare system in India is also too diversified. Primary care in India may not be is equivalent to primary care maybe in your country. So we have, all kinds of, for example, in a primary health center or a sub-center in India, you will not have anything available like the liver function test, the platelets, nothing would be available.
You cannot do a FIP4 in primary care in India.
Right?
You cannot do a FIP4 in primary.
Yes, you cannot do a FIP4 in primary care. So what I'm saying is, 3 years back, this MASL-D or NAFLD was been included in the national program on non-communicable diseases. So we are finding it very hard that how do we implement this? And for me, I think this risk stratification and screening is very, very important. So at a primary care level, there's only one worker, we call it as Anganwadi worker. She's a lady who doesn't know anything, right? She's a non-medical person. So I think for them at that level, we need to start identifying people like those who are overweight or obese. It's very easy to do. Those who are hypertensive, those who are diabetic, all
what
this
do you
high
want to do
risk.
with these people? Okay, I think we understand.
So then these patients need to go to a secondary care level. So all these high-risk group people would need screening for SLD or MASLD. And at the secondary level, if the fifth form...
So that would be 400 million people in this country.
I
Will
know,
that
I can
work?
understand that. But then I think within that, I think, as I said, we need to identify the high-risk group. And at a primary care level, only anthropometry, history of hypertension, diabetes,
So
only
you would
that can
advocate for
happen.
screening, that's what you say?
Yes.
You think we
yes.
have enough evidence to screen these people? And what should be the screening test in an Indian context? Should that be a FIP4 or, I don't know, whatever? We do a lot of other stuff with ELF tests, transient elastography. How would you, what would be the sort of the index
So once
test?
they go to a higher center where, liver functions and platelets are available, yes, FIP4 we feel is a good test for that matter. Even EPI
What would
may
you
not
then
be.
do? Below 1.3, back to primary care or to somebody else?
To the extent we have said that below one, I mean to say that there's no fibrosis at all. So if the FIP4 is less than 1, no need to go to anywhere. You're fine.
That's very low.
Yes,
And
that's
in
very
particular
low.
for older
But that
people.
would exclude all cirrhosis. We know this. The idea is to exclude all patients with fibrosis. So less than 1, you are 100% sure that nobody would have fibrosis.
Can somebody help me disagree with a cutoff by 1? Arun, you're smiling, or what? No, it's just that the risk is of a lot of false positives. You will get a lot of false positives, and that will burden the healthcare system. But that's again for SP. You are dying to say something.
Yeah, I think we need very simple things at the primary healthcare level, which are doable, which even uneducated a person who has no education can do, right? So for this, we were looking at our population, and what we found was 2 factors. One is diabetic. If a patient is diabetic, obviously, you send the patient if you are interested in only steatotic liver disease or whatever. He goes. This patient is referred. Otherwise, a patient who otherwise doesn't have these other comorbidities, then one, if his BMI is easily calculable. If his BMI is more than 23, he is almost 50% chances in India that he has steatotic liver disease. Number one. Next is a simple test. You just measure his waist. If the waist is more than half of the height, almost 80-90% he is going to have steatotic liver.
So I think
primary healthcare level, this should be a good screening test to refer to another center where he can undergo ultrasound or whatever.
Okay, that's again an interesting perspective, and also that some of these thresholds are race or regional specific, and that's probably why we can sometimes disagree, because I think a BMI threshold 23 in our end of the world will bring the whole population in, more or less. In my country, 52% have a BMI above 25, and big parts of US, that is, I don't know, a lot more. Let me then move on, and I think I'll just point you straight there, Rohit, because you already depict the drugs, because either way we like it or not, the thing that really revolutionized our fields, we see that again and again. If we don't have drug development, if we don't have the companies coming in, nothing happens. And yet we know beneath all this, we need all the preventive thing, but this is the game changer. See what will happen in Hep C, what happened in HCC. So there, could you elaborate a little bit of how do we speed up the drug development? Arun can compliment you, but yeah, please.
I completely agree. I think you asked me to be provocative. There is no reason, there wouldn't be no prevention. We wouldn't be here if you didn't have a drug to treat your patients with MASLD today. In this meeting would not have, 1/3 of its time devoted to steatotic liver disease. So that's the reality. Same thing in the United States. If we don't have drugs, physicians are not interested. And so really to understand and bring enthusiasm into a field, that disruption is needed. And so 10 years ago, nobody thought that we could have drugs that could reverse hepatic fibrosis due to steatohepatitis. Now, we don't have just one drug. We have 5 or 6 drugs that can actually reverse fibrosis. So I think thinking about NASH stage 2 or 3 fibrosis, reversing that is not even an issue. We completely think that's doable. We could do it more than 50% of our patients. So the biggest disruption that we need to talk about is, what can a hepatologist do? I'm not going to be working on, modifying the policy or public health policy in the next 5 years. The greatest, I think, disruption that we could do as a field is focus on our problem. Our biggest problem is cirrhosis. Try to find the best treatment and really focus all our energy in that. And then let other people work on, prevention and other aspects of the disease, and they'll come later, because once you find something, you have interventions to apply. When we didn't have any interventions, then nobody would want to screen anybody with steatotic liver disease. So
that was always the counter argument. What should we do? Maybe I'll run over to you a little bit about, again, because I think that we need to understand the ecosystem we navigate in, and we can like it or not, but that's the reality. And then, but again, to accelerate a drug approval, and that's basically the underlying question is surrogate markers of efficacy. So we get away with clinical endpoints or biopsy, something that can speed it up and make it lower costs.
Yeah, so first of all, I do agree with Rohit that, that without effective drug development, we would not all be sitting here, and we've seen this again and again and again. That having effective therapeutics is the catalyst for these conversations. But having said that, my perspective is that it takes a village. So it's a saying, which means it takes many different types of people to solve this big problem. So there are people within the hepatology space, like Rohit mentioned, who really should be focused on cirrhosis, understanding the biology of cirrhosis. My personal feeling is, and again, to be provocative, that the entire approach to cirrhosis drug development has been misguided so far, because the biology of the disease, once you progress to cirrhosis, is very different, and the fibrosis, it's much more complicated. And because you're not paying attention to the biology, and you're just throwing antifibrotic or some other metabolic thing and hoping something will stick, is one of the reasons why we've not made huge progress. I think there's much more to be done in terms of understanding the impact of treating the root cause in the cirrhotics, but it also requires policy change, and that requires engagement with different stakeholders. And something professional societies such as EASL, ASLD, INASL can do is really engage with all the different stakeholders. Liver disease does not live in a vacuum. When we go to policymakers, what I hear is that the diabetes guys were here just before you, and they said, we just need to control blood sugar, everything else will be okay. So who are you now again? And then the CKD guys will come right after me. So I think we have to join forces and understand that all of this action is happening in the same patient. And which brings me to my point that there has to be a convergence of this organ-centric approach to medicine to really talk about metabolic health as an integrated concept, and the importance of including the liver disease under this umbrella and developing integrated approaches, bringing all the stakeholders together, because then you can actually show that you don't have to create 5 different mechanisms for 5 different organs. Through one mechanism, you can get to everybody and make it time efficient so that you'll get more buy-in from primary care.
So you would like in future meetings to see basically sessions not about SLD or MASLD, but metabolic health?
Absolutely.
Yeah.
You know, I hate to say this in a forum of hepatologists, it's not about us, it's about our patients. And for our patients, having an integrated concept is what is the right answer. And it is not about our egos and our need to protect our own turf.
I very much agree. That will be the measure of our success. How can we actually improve the outcome of current and future patients? Sven, so you cannot pick because I pick for you. You had a beautiful talk yesterday about biomarkers. There's a lot of biomarkers. There are hundreds of biomarkers, hundreds of cutoffs, and mostly it's difficult to follow. But what are the most important things where we actually solve the biomarkers? Because in my view, the diagnostic biomarkers, it's pretty difficult to get better than where we are already. And we got pretty good prognostic ones. So, but for the monitoring and I think even more important, how do we know if the drug works or not? Because now we got drugs. Okay, we can put people on it, but when should we stop? Or when should we acknowledge, okay, this patient's benefit or this one does not? How do we get forward down that? Because that would again be the first barrier we will have when we start discussing a drug pricing, at least in Europe. Because can we get it reimbursed or not? Then they will make this integrated analysis, and then you need the tools. What should we do?
It's a complex question. First of all, with all the trials that have already been conducted and are going on, we're gathering a lot of data that will help us to answer that question. I think the answer will never be just one test. We will probably have to look at a few parameters to see whether they are improving over time. And we still have a lot of work to do to know how reliable a change over time in a given marker is and how big the change needs to be clinically meaningful. So there's still a bunch of work to do, but I think that we are making a lot of progress. First, looking at evolution of liver stiffness, for example, looking at the amount of liver fat is one of the parameters that we can have a look. And I think if
for the next step, Sven, what would be, let's say, a perfect marker for you? You know, imagine that now we look to diabetes all the time. Imagine we had an HbA1c, A1c in the liver, a good diagnostic, good prognostic, and really shows if the drug is working or not. Could you imagine such a thing for liver fibrosis, or?
I think it's a holy grail. I'm not sure that we will have such a simple biomarker to reflect the complex process going
then
on
do
in
you
the
think
liver. But
one of the reasons we are lagging behind, you can also see hypertension, it's easy. You measure blood pressure, pretty simple to measure, and again reflects diagnosis, prognosis, and if the drugs work. Do you think this is something that prevent progression in our field because it's so difficult to measure actually?
but you're saying an important point. It's about preventing progression. In drug development, we are focusing a lot on regression of the disease, which is something different. And that's also something in the clinic. I mean, what we
Sven,
want
let me
to see
stop
in
you
drug
there.
development.
So if you could choose, you've been part of this journey also for 20 years now. 10 years ago, when you advised all these people to do it like this, if you could choose, would you then have progression as a meaningful endpoint and not regression? Because I think stable disease, many people, if we control their factors, they have a stable F3, even in F4, they can do pretty well. But it's the progression to decompensate disease that drives, of course, the liver-related death. Could we imagine endpoints that are just stable disease?
Yeah, but drug development is, of course, a little bit different because you need to develop something and find the balance between risk and benefit. So you're putting the bar a little bit higher to make sure that in the end patients will benefit. But once you have a drug and a good safety risk balance, and I think in patients already preventing any progression of disease is already a win.
Thank you very much. Let's move on or shift gear a little bit. So we're almost very recently celebrating a 1-year birthday. That's normally a fragile, very happy baby. And that's the nomenclature of steatotic liver disease. That was a long and difficult journey, and most of you were in that one. And I just want to discuss how it goes. So it's endorsed by, I think, 75 societies in the world, including INASL. And I'll just maybe have a little bit around. So maybe first for you, Francesco, how's it going with integration or uptake in Europe?
I think it's going very well. As you know, of course, the first channel that we've been using for the implementation has been the EASL website and our journals. Until a few months ago, I think in May, the papers was cited in Journal of Hepatology more than 450 times, and in hepatology just a few less more, just a few less, and the same in Hepatology International. So that means in less than 1 year, more than 1,000, almost 1,500 citation. That means the implementation is going very well. And of course, we've been doing different studio in the field of SLD, and then we did a questionnaire at European level with all the national association, because the background of the EASL, of course, has to be the national association as all the big continents. And I have to say that also at the national level, they did answer very well, and then they tried to change all in the guidelines the new nomenclature, and they try to push the new nomenclature within all the national members.
Okay, so SP, how is the uptake in India? What is your impression around, is this used or, yeah, AJ, you can also take it, please. The uptake, how is the uptake in India? Is the new nomenclature used or not used, and how do you actually...
If you look at the academic program of this meeting, 2024, and the symposia, it's all MASL-D. So, and not this year, even 2023 annual meeting, we had adopted this MASL-D. So as a society, yes, as I said, INASL has already endorsed it. Now, let's come to the day-to-day clinical practice. Who's using what? I still would say, for example, large centers are like ours. You know, we are moved on to MASL-D. But then there are few centers, and maybe at a physician level, that change still may not have really happened, and we probably would need more time, more education, and more awareness for them, and the pros and cons of, you know, the new terminology. But having said that, I think we need to agree that yes, there are some limitations and shortcomings in this new nomenclature as well, and there is definitely a scope of improvement on that.
Thank you very much. So, Arun, was it worth the effort? What was, let me ask you in another way, what is the most important impact of SLD change, the nomenclature in your view? Why is this really changing things in a positive way?
I think it is a healthy thing because it depends on your perspective. So I'll give you my physician investigator perspective on this. One, that while we have always known about the overlap of alcohol and obesity and metabolic risk factors, there's never been clarity on how to define the population and to also identify whether the development of therapeutics that are designed for one very specific part of this whole spectrum is applicable to a larger segment, and that we maybe at the end of the day we'll say it doesn't really matter what you have, one size fits all with therapy, but now we have a roadmap to actually evaluate that and generate that evidence. Number two, I think one thing we don't talk about at all these meetings is what proportion of people actually have monogenic disorders hidden among our larger MASLD population. We generally tend to think, oh, that's just a rare oddity, you know, it's not a real issue. But when you look, you know, from the cardiovascular space, what we've learned is when you really start looking, people who come in, for example, with acute coronary syndrome, and if you have an LDL of 160, 8 to 9% have familial hypercholesterolemia when you actually start looking. There are partial manifestations of lipodystrophies that are linked to these people coming in with cardiovascular disorders. We have really not even scratched
So
the
you
surface.
basically see a future where we could have genetics and all. I imagine in countries like
I-
ours, most of the Danish population will soon have genetics because it doesn't cut much. Whole genome sequencing is, if you do it large scale, $100 or something.
Right. So today we are saying that, okay, why are you doing the genetics? You have no genetics-based therapeutics available. But that's going to change. Just like, you know, when you build it, they will come. That's a saying. That once we have the genomic database to show that there is a need, the therapeutics are likely to follow, because that will generate the interest. Right now, pharma companies are hesitant to engage because they're like, what's the market? Is it 1%? Is it 5%?
But don't you think that all the work with sRNAs, what GSK is doing with HSD 13B17, that will, if they're successful, then will they, okay, modifying the genes will really also be an important way forward?
Absolutely, because you know that brings us back to Rohin's original point, that when you have effective therapeutic, then suddenly everybody will say, of course, we need to do genomics in everyone. So, but I think there is really, this has opened the mechanism to actually create a roadmap for studying these subpopulations and getting much clearer understanding of these subpopulations.
But I think a key thing, again, here is the way we separate them in the silos. I agree in the real world it's a continuum. A patient actually moves a little bit back and forward, mainly because they change the alcohol consumption. So AJ, how do we actually, do we have any meaningful tool to really find these? Or should we just rely on self-reported alcohol intake? It's again, if you want to put patients on a drug, there needs to be at a certain level, or you want to put them in mid-ALD, and that actually is some sharp cutoffs, which is more difficult in clinical practice. Maybe you can, and Rohit can support, or Rohit, you want to start?
So I didn't get the question. You're
No,
saying
it was
how do we
about
decide
measuring-
on the entry point for using drugs?
No, can we report on
Met-ALD definition in
Okay,
the clinic,
okay.
and then ALD definition.
Can we measure, how can we quantify alcohol? Do we have good enough tools for that?
Yeah, no, I think we discussed this yesterday during the postgraduate course. I think we don't have very good markers, and the biomarkers which are people have used, and the PET and everything we talked about yesterday, we don't use that in our clinical practice. So for us, at least in India, it's all recall and it's all history, and which has its own limitations. People will not tell you that how much alcohol are they taking, right? And there's always a change in the amount and the duration of alcohol, which keeps changing. So I think yes, there is a problem, and so defining exactly how many would fit into
Is that the
Met-ALD.
stigma, the taboo thing that are, because I think in my end of the world, the people are relatively open, and I think with the new non-stigmatizing work, then we change things a little bit. But maybe Rohit, how would you do it? Because I guess it's an issue if you don't have the tools. But what tools would you apply, and you think we should apply those in clinical trials also?
Yeah, I think absolutely. So, you submit a paper and it'll come back to you that, oh, the way you were describing it is based upon patient recall. But that is the gold standard. I think, first of all, as a field, we need to acknowledge what is the definition of Met-ALD and what is the definition of MASLD. Now, MASLD, we all are comfortable that we asked the patient, they told us the truth, and we recorded it. In fact, most clinicians do not use audit in their clinical practice, and so it's really based upon a cursory assessment. I think we could potentially move towards a direct measure of alcohol quantification over the last 2 to 4 weeks on the index visit. And to me, that is going to be very helpful with a PET assessment. That's a direct assessment, and it's probably complementary to what you get from the questionnaires. But first is to acknowledging that with all its limitations of that particular quantitative test, set the gold standard. I think it's going to be better than Audit C or Skinner, but we should also acknowledge that currently Audit C and Skinner and Audit 50, that is the gold standard to differentiate SLD categories. And when papers are submitted to different journals, I think experts first need to acknowledge that, and that's the biggest limitation, because once we acknowledge it, then only these quantitative objective biomarkers can come in. And then we can put in fibrotic markers on top of the quantitative alcohol marker to look at disease. So to me, that's the way to really differentiate.
I very much agree, and then follow it over time. So we only have 1 minute left. I want to leave the last question to Arun, because you work so much with the drugs, and most of you have. But the next frontier is mid-ALD and ALD. There are many similarities, there are differences. So which drugs do you think stands the best chance of actually improving outcomes in mid-ALD and ALD? You have 1 minute.
So for MET-ALD, I think both GLPs and FGF21s, which are showing great promise in MASLD, probably show promise, which should work in MET-ALD as a single agent, because both have been shown to also reduce cravings. Both molecules have been shown to reduce cravings. Once you have full-blown ALD, I think it requires a two-pronged approach. We have just published with the NIAAA and the FDA a guidance document on how to do drug development for ALD with metabolic dysfunction, and requires an integration of AUD care along with ALD care, and developing a composite outcome measure that captures both of these rather disparate outcomes in one setting.
Thank you very much. That was the last point. It's 3 o'clock now, so I want to thank you, fantastic panel there, for a very nice discussion. I hope you enjoyed this more interactive format. Unfortunately, there will not be time for questions because we move on, but thank you very much for your time and your attendance.